Thank you very much for having me. It is a pleasure to be here. I was on this part of the US, so I opted to also have some learning apart from doing other issues which I was doing in the area. So our topic today is to discuss the gap between minimally invasive spine surgery and providing spine surgery in the developed world, Kenya being an example. Our key objective was to describe the gaps between MIS and open spine surgery procedures, and also to describe how to improve on spine surgical outcomes in developing countries. So that's where we come from. Kenya is on the eastern part of Africa. And basic statistics about Kenya, we are about 50 million people with a life expectancy of about 65. And spine surgery is still a young specialty, which started around 2005. We are about 100 surgeons practicing spine surgery from both orthopedic and neurosurgical training. And we formed our spine society just about 2 years ago. So the main aim of the talk is that spine surgical procedures are similar. And the key thing is that when we do spine surgery, we aim for adequate spine decompression, spinal stabilization and alignment, and spinal fusion. And our desired outcome is a short hospital stay, minimal complication rates, and early return to life activities. In Africa and in Kenya in particular, most of our procedures are still open, but we also practice some level of minimally invasive spine surgery. So just background data is that Africa has a large burden of spine pathology, but has limited and insufficient infrastructure to manage these. Although Africa has low reported prevalence of spine disorders, much of the surgical spine disease remain undiagnosed and untreated due to poor infrastructure, equipment, and human resources. Spine disorder affect about 50 million Africans annually, of which 200,000 require spine surgical procedures, but only a few are able to get it. Over the past 3 decades, innovation in image-guided spine procedures, that is navigation system, have really improved in the northern part of the globe. However, in Africa, fluoroscopy, which in itself is limited in availability, is our main navigation system. Most of our spine procedures are open. However, the desire of every spine surgeon is to use minimally invasive spine surgery whenever possible on his patient. So these are just some of the procedures that we do. Our most commonest procedures are open, discectomies, laminectomy, ACDF, lateral mass screws for C-spine, TB corpectomies, TB costotransversectomy, then open T-leaf and PLIFs, and pedicle screw rod fixation with the posterolateral grafting are the commonest procedures we do. Occasionally, we do the MIS procedures as microdiscectomy, MIS, T-leaf, PLIFs, and A-leafs. And we are trying to learn about O-leafs as well. We know that minimally invasive spine procedures have several advantages, which we desire to transfer to our patients, and these include minimal tissue injury, reduced blood loss, reduced operation time, reduced infection rates, reduced usage of narcotic analgesic post-surgery, and early return to life activities. The open spine surgery still carries the challenges of extensive soft tissue injury, increased blood loss, increased operation time, higher infection rates, longer hospital stay, and prolonged use of narcotics post-surgery. So I'll just go through some of the examples of some of the cases to illustrate our point. In the lumbar spine, our most common pathology is lumbar degenerative disease. Like in this case, is a 65-year-old female presented to us with severe back and leg pain. We opted for the open approach based on the support system available. And here we do decompression laminectomy with posterolateral grafting and pedicle screw rod system. Such an operation takes us about 2 hours to do, and blood loss of an average of 300 to 500 mL. And such patients stay for about 5 days in the hospital and are able to return to their life activities within 4 weeks or 1 month. Sometimes most of our patients present late. Like in this case, is a 70-year-old female who presented with multi-level degenerative spondylosis and stenosis at several levels. And this was done open, T12 to pelvis. And that brings the challenges of long incision and big wounds like that. However, we still were able to align the spine, decompress the patient at the stenotic points, and the patient gets discharged from the hospital within a week and return to their activity within 6 weeks. This is an example of an open T-leaf with posterior pedicle screws and rods in a 55-year-old with lower back pain and left leg radiculopathy and difficulty in walking. Again, we were able to relieve the patient's symptoms, and they were able to get back to their activity within a month. These are pretty common in Africa. I know they're not so common on this side. This is TB of the spine, commonly at the thoracolumbar junction. We do this in open form, in form of the approaching it from posterior and the lateral side. So we use a pedicle screw and rod system and a variable cage system introduced after corpectomy. They stay in the hospital for quite some time, usually about 2 weeks. And then the patient was able to regain power and was ambulant and back to activity within 3 months. This is another example of a 52-year-old with lower back pain and radiculopathy and other grade 1 spondylolisthesis. So this is a case we opted to do a PLIF. The hospital stay was 4 days, and the patient was back to work within a month. It is a peak cage. We can see the markers there. Then lastly, this is a 57-year-old presenting with symptoms of disc disease at L5S1. The other levels were essentially okay. So this is one of the cases I did with one of the visiting colleagues, visiting surgeon who was working with us, who was showing us how to do an ELIF at that level, L5S1. And we realized the patient hospital stay was reduced, was discharged the following day, and had a good result. In the cervical spine, we mainly do SCDFs and lateral mass screws. So this is an example of an SCDF at C5, C6. And the results are more or less the same with what other colleagues have described here. So in summary, there is a big gap between minimally invasive spine surgery and open procedures based on the previous speakers and the technology that I've listened to since this morning. However, MIS spine surgical procedures is the future. So the gap in providing MIS spine surgery in developing countries, however huge, should be the way to go. This will require investments in infrastructure, equipment, and training of surgeons in that part of the world so as to bridge the gap. This could be done through collaborations, through spine camps, spine training in form of short fellowships. We don't have established cadaver labs like it is here, so that would be one of the ways to practice MIS before you do it on real patients. So we hope that spine surgical outcomes will improve in the developing countries with such collaborations. Like that is about 2015. These used to be some of the volunteers who would come to Kenya and we would work together. You might be able to recognize some of the faces. Oh, yeah. Thank you very much.
Thanks, Dr. Otieno. Great presentation and actually very informative. So Spine Society is that new to Kenya. It started in 2005. And
yeah, that's when it peaked. Before 2005, at 2005, we just had about less than 10 spine surgeons.
Okay.
And
is it a public health system? I mean, how is it paid? How does that work?
Yeah, the big challenge across Africa is that we don't have much of the health insurance in the population. Currently in Kenya, for the population of 50 million, we have about people with some insurance, about 12%. So most of our patients do present on time or come late due to financial challenges. And upon making a diagnosis of what you want to do as a surgeon, then they require time to put their resources together before the procedure is done. We have several companies, including Medtronic, Dupui, and several other generics from China, India, and Europe, providing implants, but these implants need to be paid for upfront before a surgery is done because of lack of insurance.
Sorry, yeah, it's just a really nice presentation. You know, we do some work in Tanzania, so we've been going there for a number of years, and the biggest challenge for spine surgery is indeed, as you mentioned, is that patients have to pay for the implants, not only for elective surgery, but also for trauma, which is crazy. But it's a real challenge, and so therefore I think really MIS surgery, where the implants are even more expensive usually than regular, I mean, it's a real challenge. On the other hand, though, what I think in terms of a leapfrogging thing is endoscopic surgery, right? We tried tubular surgery in Tanzania, which I thought would be great, but it turns out it's very difficult because of epidural bleeding. And if you have epidural bleeding during a case, you don't have any hemostatic agents. I mean, we don't realize how much flow seal and gel form and thrombin we use in these cases, and they don't have that. So tubular surgery is a problem. But I think endoscopic surgery may really be a huge benefit for your part of the world. Have you had any experience with that?
Yes.
Not for implants, obviously, but for decompression, for degenerative.
For decompressions. Yeah, that really works well. We have a few colleagues we work together on for doing discectomies. Then you could be able to do it with the tubes. However, most of our patients, the issue of late presentation, so they present with a pathology which is already advanced, and which most of the time will require some level of instrumentation, because it tends to be 3-4 levels that you're dealing with, and hardly single levels. Single levels will be for the younger patients who are just lifting something and have a single level disc disease. And the ones with the infections, pyogenic or TB, also usually is multiple levels. So they'll require a variable cage and pedicle screws as well.
Yeah, you probably don't remember where we actually met a long time ago in Nairobi.
Yeah,
and what you're able to do with the equipment you have is really, really amazing. What you're able to do there, it's just so impressive. And you're asking about the implants. If you remember, we used to sneak them across the border not pay for them when they came in through through customs, because the implants you don't use in the States or that are expired, you can actually bring in and use. So we would collect them and brought them in. But I don't think I've been there in a few years. I can't remember even what year it was, probably 2010. But thank you for the presentation. And I can remember walking through Kibera with you, actually, and looking at patients there, which is an amazing spot.
Yes, I remember very well. We worked with you in Kenyatta National Hospital with Pichu. Yeah. Yes.
I really enjoyed your talk. Thank you. Just having been, I don't know, 3 continents, 8 universities or whatever, and watched India, China grow since the 80s, right? There are many, many things, you're right, there are issues. But one thing for sure is you do not need Western technology to be good. I will tell you that for an absolute fact. You can use what's in there, indigenous in you, to use it. What does that mean? Whatever metal you got, make the implant. You can do it. Across the street, that blacksmith will make it for you. It doesn't matter. It's better than nothing. Now, microscope. Get the oldest microscopes. You can do laminoforaminotomy and move from laminectomies and start doing minimally invasive things. Minimally invasive, more procedures. Don't get bogged down that you need, every company is killing me right now. Don't get bogged down that you need this equipment there. You can take it and use that technology in your own way and be indigenous in what you developed there. China did it, India did it for years. In the 80s and 90s, we made every implant, copied it next door. We should walk next door, have this guy make it out of 360 and stainless steel. And I can tell you, 80, 90% did very well. They did really well. And it works. So you have to be indigenous in your own way to make it happen. And it will happen. And then as it gets better, it gets better and better. But thank you for sharing what you did.
Thank you very much. Yeah, totally agree.
Are there training programs for spine surgeons in Kenya?
Currently, we don't have formal spine fellowships. We're just about to start it. We formed the society 2 years ago. So most of us trained outside Kenya to do spine surgery. Yes.
Thank you.
You're welcome.
Yeah. So we're planning on moving on with our next cadaver demonstration, and I think this is going to be very interesting. Paul Holman's going to talk or show us how he